Hello, everybody. I'm Waqar Ahmed, and along with me, representing from Euro Intervention, is we are going to host with us our doctors. I will let them introduce themselves. They are part of the ERCTO Registry, the senior author and the first author.
Good morning. I'm Dr. Vadalà. I'm Professor Galassi assistant working in Palermo and at the University Hospital. Together with me, everybody know there is the Professor Galassi, one of the sensei, as they call him in the CTO interventions. Very glad to be here with you and to share the finding of our paper. Thank you.
Welcome,
for the
Professor
opportunity.
Galassi and Dr. Vadalà. I have a few questions for you guys and that our audience may be interested in. First of all, what was the main idea behind the ERCTO registry? There's already the Progress Registry in USA and internationally. So how did you select the sites and the operators?
First, let me tell you about the background, because you know that during the last years, we focused our attention mostly on the technical success of the procedure that actually are over 90%. But what is really important now, because no doubt about the fact that CTO PCI can be done with very high success rate, but is the complication, evaluation of the complication, especially because this kind of procedure have a higher complication rate as compared to the non-CTO PCI. Is still debated if the reduction of MACE outcome is so good. So the need to overcome with this issue is essential, and to better realize how the CTO PCI works around the world are the registries. And besides Progress from the United States, the ERCTO Registry are one of the largest registries in the world. Obviously, by a scientific point of view, trials have a greater value than registries. But you know, trials have a lot of limitations, not always reflect the real world population, while the registries maybe represent more properly what's really happening in our cath lab every day. That's why the need to use the huge amount of data the ERCTO registry provides us. This is the main point.
And indeed, in this, according to your questions, which are the centers selected, the center are not really the center, but the operator, which are high volume and medium volume operator, CTO interventions, and this is basically giving support to the idea also, and compare those operators who are very skilled and very high volume as compared to those who are medium volume. And this is in the registry of ERCTO registry is also updated during the last year.
So my question is, how did you choose the operators?
But wait. Back to your questions. To participate the ERCTO registry, you must be part of the EuroCTO club. You must be certified to be an operator involved in complex PCI. And we define two ranks of expertise. High volume operator, called members, are operator that with an experience certified by the record in the ERCTO registry of more than 300 procedure and the volume of procedure larger than 50 CTO PCI per year. And it is quite similar to the Japanese registries. The credentialing are very similar. Besides, next to the very expert operator, there are the so-called candidates that they still don't have a lot of experience, but the mean volume for this mid-volume operator, that we call them mid-volume operator, is roughly 27 procedures per year. And it is in the middle between the Japanese and the progress, where I can guess that the paper was from Caraxo Coni. In the progress registry, we can identify the three ranks of operator expertise: low volume, performing less than 30 procedures; mid volume, between 30 and 60 CTO PCI per year; and high volume, larger than 60 years. So you can realize that around the world, the way you define the expertise is not always consistent. Please.
Yeah, actually, you bring up a very good point. Your registry clearly showed the difference between high volume operator and the mid volume operator as defined by the registry. Now, the high volume operators had better outcomes.
Yeah.
And one of the limitations you mentioned in the paper itself is that it's a self-reported registry.
Yeah, you know,
without an external audit. So how can we be sure that people are reporting all their cases? Maybe they're just reporting their best cases and not reporting their poor outcome cases.
This is a common limitation among the prospective registries without an external committee evaluating not only why some patient could have been ruled out before enrollment or after the procedure, but even the adjudication of adverse events. This is another point. But besides this limitation, as I told before, maybe there is many things that be good that we could take by these registries. On the other hand, trials have a more proper adjudication of events, but you know, the enrollment is slow. Generally speaking, it was a common behavior in the ERCTO trial, in the open CTO. In the trials, population is very selective, have been excluded more symptomatic patients, those patients with a very depressed left ventricular ejection fraction. So for both of them, we have point of strength and of weakness.
Sure. Now, actually, yeah. So how do you recommend, after looking at your registry data, that a mid-volume operator become a high-volume operator?
First of all, you need time to perform more procedure, to become to reach those level of expertise necessary. Maybe the proctoring program are essential because actually we have many tools to anticipate the complexity of the procedure based on a properly done dual angiography. If you don't have enough information, you could use the coronary CT scan to better understand I don't know, the course of the CTO, the distribution of classification. So actually we have all the tools to anticipate how complex is a procedure. And if you are in this case, probably you could advantage by performing the procedure together with a very expert operator. I'm very happy to working together with Professor Galassi, but I think that around the world always is possible to have a proctorship.
One of the problems I think that it is really important to address is the issue that sometimes in some centers there are many operators doing CTO. And this probably does not help the center itself to improve the percentage of success. So probably I would say that nowadays we should look forward and try to identify inside the cath lab specialized people who are dealing with CTO or doing structural interventions or doing TAVI. And I think the future might be more and more important to do to go in this direction, because this may help the procedure to be quicker, more successful, and with less complication.
I think that's very good. I think because of the time, I only have two final points. One of them is imaging use was extremely low in the registry, and now everybody recommends doing imaging, IVUS, and possible OCT, but definitely IVUS for CTO in all complex cases. Everybody talks about imaging, but in real life now we see a very low use. How do you put that in perspective?
The IVUS use, the mean IVUS use was roughly 22%, but there is a great difference among different operators and countries. There are operators that use IVUS in 80% of the procedures and other 10%. It depends on cost issue reimbursement first. Secondly, that sometimes the use of IVUS could make the procedure more complex if the operator is not very much confident, because during the CTO procedure, IVUS is not only used to optimize stent implantation, to define stent size and so on, but could be crucial in some step of the procedure that can be addressed only by very expert operator. Such an example, I don't know, the puncture of the blunt cap, or to guide the re-entry in case you are in the situation of ADR with a difficult distal re-entry, and to define where the wire is, intraplaque, extraplaque. So maybe these are the reason why could be sometimes tricky use IVUS, but I definitely agree that it is essential to improve safety and effectiveness of our procedure.
So for final point, what is the lessons that you want the world to take home about the registry?
I don't know. I would like to share my idea with Professor Galassi, that is a wise operator about it. The data tell us that there are different degrees of lesion complexity, and that one approach is useful and effective in a proportion of cases, but the more complex CTO lesions must be approached using maybe a retrograde approach that have a higher rate of complication, but you have to accept this, otherwise you don't succeed in CTO regionalization. Secondly, once you decide to use alternative regionalization options, I mean retrograde or anterior dissection re-entry, you must be an expert operator, because it's clear that if you are very expert, your complication rate in the European experience is lower than less experienced operator. And maybe the operator expertise could be essential to decide which CTO maybe should be left untreated because not clinically indicated, but it's just a job to succeed in regionalized imaging that is closed by since many years, and concentrate your efforts in those CTO which regionalization could determine a great benefit for the patients.
Yes, to summarize, I think that we understood that more and more often we are doing integrated approach because of the new guide wires that are able to penetrate into the CTO and recognize the artery in successful as compared to the past. Additionally, we also learned that the retrograde approach, despite being more complex, as Dr. Vadalà is saying, is also in expert hands, probably has a good rate of success, and despite having more complications, which are mainly perforation, but not really major complications. And finally, we also learned that many cases, the most complex ones, probably they should be successed by ADR technique. And probably wire-based ADR technique rather than device-based ADR technique is probably more and more used often. It's more often used than in the past. And nowadays, investment procedure may be also an option in case we are not able to successfully recanalize the artery with the ADR technique. And I think, having said that, we must push the new fellows that are starting this work to be concentrated on each of these techniques and trying to get more experience individually on each technique and then go ahead with the new technique with the proctor.
Thank you both very much.